Hey guys, Dr. Mimi here with Virginia Preventive Medicine and Wellness, and I wanted to make a video. This one's for you guys who are either taking testosterone or you're interested in taking it, and you want to know a little more about the side effects and risks. It's really easy to find videos on all the benefits because that's what we always want to talk about, but you rarely see a video on side effects. And just like every other drug out there, the package insert for testosterone that lists potential side effects and risks, it seems like it's a mile long. So how do you know which ones are real or common, and then which ones are on there just because their attorneys probably made them do it? Anytime a potential side effect from a medication is reported to the FDA, it's their job to warn the public of that, and so it goes on the list. For instance, a sinus infection is on the list of side effects for testosterone. I don't really think that the sinus infection was caused by testosterone, but that's what was reported, so that's what goes on the list. With all that said, there are some real side effects that I'm going to talk about, and most of them you don't actually feel or notice per se. And then there are some others that are a little more theoretical. These are the bad ones that you hear about sometimes, like prostate cancer, blood clots, heart attacks, and strokes. Are they real? Are they actually evidence-based? We'll look at that. But first, I want to go quickly through the side effects that can happen or will happen. And the first on that list, the first potential side effect, is acne. Some guys will develop some acne. If it occurs, it's usually on the chest, on the shoulders, or the back. It's not common, but it's not uncommon either. And it's really hard to predict who won't get acne. And it's due to the testosterone being metabolized to DHT, which is a dihydrotestosterone. That increases sebum production in the skin, and that sebum is basically food for acne-causing bacteria. And this acne, it can be treated with like an antibiotic or a good soap scrub. There's a lot of different angles of attack that I use to treat this. So moving on to number 2, testosterone replacement is going to shut off your own production of testosterone. When your levels get high enough from replacement, there's a negative feedback loop. Your body detects that new level and it says, hey, I don't need to keep making this anymore. I have plenty. Your own production, it does come back if you stop the testosterone, but it can take a couple of months to get back to where you would be otherwise. Number 3, and this one kind of along those same lines, when your testicles stop making your testosterone, you will also turn off, or at least turn down, your own sperm production, because sperm production requires intratesticular testosterone, testosterone that's actually being produced inside the testicle. And what you're taking as replacement therapy doesn't really get into the testicles enough to keep your sperm production going. So for many, or if not most guys, this will either cause subfertile or an infertile sperm cell count. There are some evidence-based ways of getting around this by using HCG. And you also see a lot of posts on forums and social media support groups of these different guys out there saying, well, I had kids no problem while taking testosterone. Maybe, and that's a pretty risky gamble, and I would say it's more likely the exception than the rule. Number 4 is testicular atrophy. I'm sorry, guys, this one is true. Some guys, it's not at all. Most guys, it's a little bit, and for the rare guy, it can be fairly substantial, and you just can't predict which of those groups you're going to fall into. The size does come back if you stop testosterone, but I'll be honest with you, most guys, once they experience that difference in going from a low testosterone level up to excellent levels, the size of your testicles, it really becomes the last thing that you're worried about, and you're probably not going to stop testosterone because of it. But it is a side effect, so you should know about it. Number 5. This one's one that I hear talked about, but it isn't really true. And that's liver toxicity. The testosterone prescribed today in the United States, at least, it doesn't cause liver dysfunction. But when you look at the depot testosterone monograph from Pfizer, the pharmaceutical company, it has it listed as a side effect. But you really have to read the fine print. There's a quick little blurb further down. It says that 17-alpha alkylated oral testosterone has been known to cause liver toxicity. No testosterone you're going to find as a prescription in the United States is alkylated at that 17-alpha carbon. It's listed as a side effect, though, in all testosterone products because the FDA requires that all medications within a class of medications carry the same list of side effects. And because prescription testosterone and alkylated oral testosterone fall under the same class, they both have to carry that side effect, even though it's not really true for prescription testosterone. Number 6 is, this one's probably the most controversial. A very tiny percentage of your testosterone is going to be converted into estradiol. And there's this school of thought out there, usually by doctors that are trained by some of these anti-aging academies, that this conversion needs to be managed and that the high levels of estradiol might be harmful. If your estradiol is too high, it can cause erectile dysfunction, poor libido, it can cause weight gain, man boobs. No, nothing could really be further from the truth. And this idea comes from a misunderstanding of what the medical literature actually says. Is high estradiol associated with all of those things? Yeah, it is in every study, but it doesn't cause it. Did I just contradict myself? No. And I really need to make a separate video on this and explain what I mean, because it does take a little bit of time. But once you have that insight into what the studies actually say, it becomes a whole lot more clear. I never block estradiol in men on testosterone. I want it to be high because it actually improves all of those things. Number 7 and number 8, finishing up this with hair loss and gynecomastia. Gynecomastia is the man boobs, so to speak. If you have a strong family history of male pattern baldness, then there's a theory that your testosterone may speed up that process. But the evidence behind that is lacking. If your testosterone level is over 200 or so already, it's very unlikely that replacement is going to affect hair loss. And then for gynecomastia, testosterone doesn't cause gynecomastia, in my opinion. Hormone imbalances cause gynecomastia, as can a lot of other things. Fix the hormones, you don't have to worry about it. If you already have gynecomastia, then the situation is a little more complex and outside of the scope of this video for sure. You also have to understand the difference between true gynecomastia and pseudo-gynecomastia. All right, so let's move on to the big ones. These are the potential risks that, if they were true, they could cause serious harm. That's the ones we just mentioned: the prostate cancer, blood clots, heart attacks, strokes. Are these reported risks actually based on solid evidence from the medical literature? And that's what the bulk of this video is going to be about. Full disclaimer up front, I'm going to be making a lot of references to Abraham Morgantaler in this video. And if you're not familiar with Dr. Morgantaler, he's a very well-known urologist out of Harvard University. He spent his entire 45-plus year career doing research and publishing on testosterone, especially regarding testosterone and prostate cancer. And his work has quite literally turned upside down some of the long-standing practices in the field of urology. Okay, so potential risk number 1. Let's start with prostate cancer, because that's the reported risk of testosterone replacement that's probably been around the longest, probably 70, 80 plus years. And it was based on a single study published by Huggins and Hodges in the 1930s. And when you really analyze the data, it really only reported on one man with metastatic prostate cancer. And he was given testosterone injections, and they measured his acid phosphatase levels, which is what they were using to monitor his metastatic disease. So for 60, 70 plus years, it was taught as true, it was unquestionable that testosterone caused prostate cancer based on this one study that really only had one patient who was hormonally intact, and he was given testosterone for only 14 days. And his acid phosphatase level is kind of up and down, it's uninterpretable. So thanks to the work of Dr. Morgantaler, we know this isn't really true. The American Urological Association says in its guidelines on testosterone replacement, number 17 says, clinicians should inform patients of the absence of evidence linking testosterone therapy to the development of prostate cancer. This is somewhat of a complex topic, though, because prostate cancer cells do have receptors on them for testosterone, and that can stimulate growth of that prostate cancer. But there are only so many so many receptors available for testosterone to bind onto. So once your testosterone level is over 100 to 200, those receptors become saturated. You could crank that testosterone level up to 2,000, 3,000. You're not going to stimulate that prostate cancer to grow any more or any faster than if your level is, say, 250. It's called the saturation model, also called the bipolar testosterone concept. It's introduced by Morgantaler, 15, 20 years or so ago. It's acknowledged and recognized by the American Urological Association as valid. It's based on some additional research that has supported it. The next part is, what if a man has prostate cancer, but is just on active surveillance? Can he be treated with testosterone? And active surveillance, it just means that prostate cancer is very slow growing and it hasn't spread outside the prostate. Therefore, the man can delay treatment because the treatment for prostate cancer is not very fun. So what they do is they just check PSA levels a few times a year. They might do a prostate biopsy once every year, 2 or 3. And the panel says here regarding this that if a man has prostate cancer and he's on active surveillance, then whether or not he should start testosterone treatment is really a negotiated decision based on that perceived potential benefit. All right, so that's prostate cancer, and that's why the guidelines for screening for prostate cancer in men on testosterone are no different than the man not on testosterone. You just screen based on age, on race, on family history, which are the risk factors for every other man. Okay, potential risk number 2, that's blood clots. This one is one that's commonly believed based on a misunderstanding. But before I dive into my own professional take here, let me tell you again what the American Urological Association says on its guidelines. It says on number 19, patients should be informed that there is no definitive evidence linking testosterone therapy to a higher incidence of venothrombotic events. That's blood clots. Goes on to talk about, the concern about the possible association, not causation, association between testosterone therapy and blood clots led the FDA to require pharmaceutical companies to add this warning to their product after it went on the market. This decision was based on anecdotal cases, not peer-reviewed literature. Since the FDA warning in June 2014, 4 large studies have been conducted, none of which showed an association between testosterone therapy and an increased risk of blood clots. So, do I think that testosterone therapy causes blood clots? No, I do not. The medical literature just doesn't support it. Do I tell my patients that the FDA has it listed as a potential side effect? Absolutely, I do. That's my job. And if you start testosterone with me, you'll sign a consent form stating that I have warned you about all these purported side effects. And then I'll tell you my own professional opinion that's based on the medical literature. The reason people, including a lot of doctors, unfortunately, think that testosterone causes blood clots or increases your risk, it's a little bit complex, and I'm going to try to keep this brief, not get too far down into the weeds, which I tend to do. So testosterone replacement in most guys, it's going to increase their red blood cell count. A high red blood cell count is called erythrocytosis, and we monitor with labs the hemoglobin and hematocrit to follow this. And hemoglobin is just a protein on your red blood cell. And when we measure it, we kind of get an indirect measurement of your red blood cell count. And then hematocrit is just the volume percentage of red blood cells in your blood. So as a general rule, for you guys, about 48% of your blood is made up of red blood cells. So then your hematocrit is also 48%. That's all it means. So testosterone can stimulate red blood cell production and increase both of these two measurements. So when you increase your red blood cell count, the theory is that you're causing your blood to become thicker. And if your blood is thicker, well, then it might cause a blood clot. I've heard a lot of people, including some doctors, yes, confuse this with polycythemia vera. It's not this polycythemia vera. Polycythemia vera is a blood cancer. And yes, patients with that disease have a higher incidence of blood clots. And yes, they also have a higher red blood cell count. So a lot of people take these two concepts of polycythemia vera, higher red blood cell count, definitely a risk of blood clots. With testosterone, higher red blood cell count, maybe thicker blood. Oh, they sound kind of similar, so maybe testosterone causes blood clots too. Well, that's a very large assumption, and that's extrapolating. And that extrapolation isn't really based on any medical literature, because they've kind of missed the most important part. With polycythemia vera, it's not the red blood cell count that causes the blood clots, even though we do use the red blood cell count to monitor the disease. Polycythemia vera causes an increase in white blood cells and platelets, and that's what increases the risk of blood clots. I want to read something else here. This is published in the Clinical Advances in Hematology and Oncology, January 2019. This is by Dr. Prashal. He's the Division of Hematology, Hematologic Malignancies, University of Utah, Huntsman Cancer Institute. And this is what he writes. Common dogma dictates that a high hematocrit is the cause of blood thickening and blood clots. No evidence exists that a high hematocrit is harmful and a direct cause of thrombosis. In addition, many conditions that lead to a very high hematocrit are not associated with blood clots. These include, among some others, testosterone-induced erythrocytosis. And then a little bit further down, he says the single best blood cell parameter that correlates with blood clots in polycythemia vera is the leukocyte count, or the white blood cell count. Thought that was interesting. So what it all boils down to is that people confuse the terms secondary erythrocytosis, which is a high red blood cell count caused by something else, in this case is testosterone, with polycythemia vera, which is an increase in red blood cells. Yes, but more importantly, the platelets in the white blood cells, which is the real reason for the blood clots. And you can think about it this way too. You know, there are upwards of 500 million people in the world who live in mountainous regions, elevations of 7,500 feet or greater. The lower oxygen levels up there kind of force their bodies to make more red blood cells so they have better oxygen carrying capacity. So they live with these chronically elevated hemoglobins and hematocrits. These are levels that are equal to or greater than what we see with testosterone replacement. What do you think their risk of blood clots is? I mean, based on this concept that high red blood cell count increases clot risk due to that thicker blood, they must have a higher risk, right? Well, no, they don't. Their risk is no different than that of people who live at sea level with a normal hemoglobin. And it's the same physiologic mechanism in both testosterone replacement and high elevation that drives that high red blood cell count. So do we tell people in the mountains, look, you got to come down here and live by the ocean, or you're going to get a blood clot? No, we don't. They're doing just fine up there. So I don't want to keep beating a dead horse here, but this is just one of those dogmas that's unsupported by 40 plus years of research, and it just won't die for some reason. And you can find a particular researcher out there who publishes studies where he gives testosterone to men with blood clotting diseases without a control group. And then when those men have the blood clot that they're going to have anyways, he says, oh, see, testosterone causes blood clots. That gets reported to the FDA, and what do? Well, they do their job. They report what was reported to them, to the public, and they require it to be listed on to be placed on that list of side effects. Last but not least for this video is side effect number 3, heart attacks and strokes. And I group these together and we call them cardiovascular disease because both heart attacks and strokes are problems in the blood vessels, and they often arise from the same disease process. So I'm going to give a quick version of this for those of you who are already bored, and then I'm going to go a little more in depth afterwards because this idea that testosterone causes heart attacks and strokes, it's relatively new, and it's based on some very weak data that I'm going to show you. So let's start off again by reading what the American Urological Association says about it. Guideline number 20. Prior to initiating treatment, clinicians should counsel patients that at this time it cannot be stated definitively whether testosterone therapy increases or decreases the risk of cardiovascular events. Now I'm happy that they didn't just come out and say, well, testosterone might increase your risk, like some medical society guidelines do. But I'm also a little disappointed that they didn't take a more aggressive stance on this one because there is just very little, if any, credible evidence that testosterone causes heart attacks or strokes. It's just not there. On the other hand, there's a lot of data to suggest that it does not increase the risk, and then there's even more data to suggest that it protects against cardiovascular disease. I mean, if it was testosterone itself that caused these heart attacks and strokes, then why aren't young men with their naturally high levels of 900, 1,000, 1,200 just having heart attacks and strokes left and right? But it's not until we start getting older and our testosterone level decreases that our risk of heart attacks and strokes starts to go up. They do go on to say that low testosterone levels are associated with a higher risk of cardiovascular disease. And then they also say that until there is more substantial research to show that it might increase risk, this panel recommends that clinicians counsel their patients that the current scientific literature does not demonstrate that testosterone increases cardiovascular risk. So if you're satisfied with that as an answer, feel free to turn this video off because that's it for the side effects. But if you want to hear more about these studies that many doctors and medical organizations and journalists and websites reference to say that testosterone does increase your risk of heart attacks and strokes, keep watching because it's pretty astounding how terrible these studies actually are. So interestingly, just as this notion that testosterone causes prostate cancer was starting to lose traction and die off, and studies were coming out showing that we had been doing it wrong for 60 years, suddenly in 2013, early 2014, comes this surge of concern about it causing heart attacks based on two studies that came out at that time that suggested there was an increased risk. So New York Times got a hold of it, wrote this big sensationalist piece about the dangers of testosterone based on these two studies. Other media outlets picked it up, ran with it. Everybody just started losing their minds basically. And cardiologists were calling up their patients and saying, oh, you've got to get off this testosterone, it might kill you. There were lawsuits against pharmaceutical companies who made it. So you would think, based on that kind of response, wow, these studies must be pretty bad, and of course thoroughly vetted before publication. Well, they were published in the Journal of the American Medical Association, PLOS 1, the Public Library of Science, and then another one actually was published in the New England Journal of Medicine, and I'm going to talk about that one too. And these are the high rollers, these are the big leagues in medical literature, and this has to go through statisticians and epidemiologists and all the scientific and physician editors, to get published in these peer-reviewed journals. So let's take a look at the first of these two journals, and it's called the Association of Testosterone Therapy with Mortality, Myocardial Infarction, and Stroke in Men with Low Testosterone, published in JAMA, November 2013 by Vegan et al. This study started by looking at about 8,700 individuals. This wasn't a study where they gave testosterone and then observed over time what happens. That's an interventional study, and that's a good one. This was a retrospective review of data that they obtained from the VA hospital system. So they got records from 2005 to 2011. They data mined those records, and they found men who met two criteria. The first was that they had undergone a coronary angiography, okay? And the second was that they had had their testosterone levels checked, and they were found to be low. So that's your study group, okay? And then they divided that group of men into two groups. One group was the men who went on to get treated with testosterone, and the other group was the men who did not get treated with testosterone. And again, this didn't all happen at the same time. Remember, these were medical records from men over a 6-year period. So they looked through the charts at the 3-year window following their coronary angiography. And then they looked at which groups had more events of either death, heart attacks, or strokes in the men who had received the testosterone versus the men who did not. So the results that they published were for the absolute rate of events, meaning they had had a heart attack, stroke, or died. They said that in the testosterone treated group, there were the absolute rate of events was 25.7% of those men had an event, while 19.9% of the men who did not get testosterone had one of those events. So their conclusion was testosterone increases your risk of death, heart attack, or stroke. Except this isn't true. When you add up the total number of events and divide by the number of men in that group, the men in the testosterone group had a rate of events of 10.1, and the untreated group was 21.7. So the guys getting testosterone had half the rate of heart attack, stroke, or death compared to the untreated guys. So what happened? How is it possible that such a large mistake was published in JAMA and nobody caught it? Well, They initially published that it was the absolute rate of events, but it wasn't. A couple of months later, the authors made a correction and replaced the term absolute rate of events with Kaplan-Meier estimated cumulative percentages with events. And they had used a brand new statistical method that had only been described about a year before, published. It had never been used in a study like this, and the author of that method said himself in his paper that this method lacked documented accuracy. They called this method stabilized inverse propensity treatment weighting applied to Kaplan-Meier curve with time as a covariate. Well, that's very statistical. Why not just use the absolute rate of events in your true groups here that have already been matched to minimize confounding? Well, that would change the outcome. On top of all that, later corrections show that the numbers for one group had increased by more than 1,000, second group decreased by more than 900, and then nearly 10% of that all-male data set was found to be women. Nice. Talk about mismanagement of data. Okay, quickly moving on. I know this video is getting long. The second study that's always referenced was by Finkel et al. It was published just a couple of months after the previous study that we just mentioned by Vegan. It's called Increased Risk of Myocardial Infarction Following Testosterone Therapy Prescription in Men. This paper is almost always referenced when you see or hear someone saying that testosterone increases risk of heart attacks. There are so many problems with this paper that some have speculated that it never would have been accepted for publication if it hadn't been able to piggyback off of this newfound concern of cardiovascular disease that was triggered by the Vegan study. So this Finkel study was, again, a retrospective review of an insurance database. All of this information came from insurance claims. No clinical information was available other than a diagnosis code and a prescription use. Were these men obese? Did they smoke? What were their labs? They didn't know. They data mined these records, these medical records, for a diagnosis code of heart attack within 90 days of getting a prescription for testosterone. That's it. And they compared these results to men who had received a prescription for Viagra or Cialis and also had a heart attack within 90 days. I'm sorry, did I just say that their control group was a group of dissimilar men with dissimilar problems getting a dissimilar medication? Yes, I did. Interesting. And that's the evidence that they use to say that testosterone increases risk of heart attacks in men? I guess it is. But even if you consider that a valid study design, what were the actual results? What did they publish that what happened to the testosterone treated group? They reported that there was one extra non-fatal heart attack per 1,000 person years in the testosterone group. What does that even mean, 1,000 person years? So I'm going to, again, borrow from Dr. Morgantaler, who made it a little easier for me to understand this in one of his lectures. So let's say a man starts testosterone this year 2022, and he uses it for 10 years. So that's 10 person years of exposure. 20 years later, his son uses it for 10 years. That's 20 person years of exposure. 20 years later, the grandson uses it for 10 years. So that's 30 person years of exposure. So if this trend continues indefinitely, where one son in each generation uses testosterone for 10 years, how long would it take for a heart attack to occur within that family line from using testosterone? It would take 100 generations before we see that one event, and it would be the year 4022. So even if you believe this is a valid study, like Morgentaler said, this might be statistically significant, but it's really clinically meaningless. But really the most disturbing thing about this study isn't the data that was published or the results that was published. It was what was left out. Because the lead author of this publication was also the owner of Consolidated Research Incorporated. That's the company that owned this medical data. All of the authors were his employees. So when you are publishing a study, you want it to be as high powered as possible. And the longer your study period is, the more power your study has behind it, and the more reliable and credible the results are, right? That makes sense. But they only included data for 90 days. but they had access to far more data than that. If they had increased the study period to, say, a year or more, it would have increased the reliability, but they didn't. And the only reason I can think of why you would intentionally decrease the statistical power of your study is if it changes the results to something different than what you want to publish. I can't think of any other reason why you would choose 90 days and lower power instead of a year and higher power and more reliability. They had access to that data. Why not use it? So, okay, let's wrap this up with the last of the 3 studies that you always see quoted when talking about these risks. This last one is by Basaria et al. It is a randomized, placebo-controlled, double-blinded trial. That's a good one. However, one of the main problems with this study is that it was not designed to look at cardiovascular outcomes. The purpose of this study, and how it was designed, was to see how men who are frail respond to testosterone. So the study group was old men with limited mobility, and they defined that as they couldn't walk more than 2 blocks on an even surface, or they could not climb more than 10 steps. That's pretty frail, that's pretty deconditioned. 60% of them had pre-existing cardiovascular disease, 50% were obese, 80% had hypertension, 25% were diabetic, 56% had hyperlipidemia, and 65% were either smokers or former smokers. All of these are significant risk factors for heart attacks and strokes. So in this group, you have the testosterone group and the control group who got the placebo. The primary outcome studied, and it was designed for this, was changes in leg press strength. Secondary outcomes were chest press strength and stair climbing with a load, etc. So they put all these guys in the gym and they had them get to work. However, the study was stopped early because it was being reported that the guys getting testosterone were having a higher rate of cardiovascular adverse events. The report was 23 events in the testosterone group versus 5 events in the control group. And one of the problems here is what they considered a cardiovascular adverse event. For instance, the most common reported event was swelling of the feet, also syncope, elevated blood pressure, whatever that means, not defined, chest pain, ectopy on EKG, like premature ventricular contractions. So these are all some pretty soft events, first of all, and they are of some questionable clinical significance. And second of all, many of them were just self-reported by the patients, or they were just notated on the medical chart. All of the men on testosterone had significantly greater increases in leg strength, chest press strength, stair climbing power with a load than the non-testosterone group. But there were 5 events in the testosterone group, and that included, death, 1 death by heart attack, 2 by a non-fatal stroke, 2 non-fatal heart attacks. So should that raise concern? Well, we shouldn't ignore it per se, but we have to look at the strength of the study. And the author himself says in this study that the events may have been due to chance alone and to not draw conclusions. Interestingly, 5 years later, he published another study that was designed to look at cardiovascular outcomes in these old, frail men, and the result was no increased risk. Similarly, the European Aging Male study, designed the same way, showed no increased risk. But no one seems to pay any attention to those studies and the hundreds of others that are just like them. We like to look at this flawed study that tells us, I guess, what we want to hear. So I say the takeaway from this study is just be careful giving frail, elderly, deconditioned men that probably haven't set foot in a gym in 20 years a hormone that increases their energy, gives them motivation, gives them their drive back, and then put them in a gym and say, give it all you got, Theodore. So those are the 3 studies that I wanted to tell you about. Even the FDA came out and publicly acknowledged the weakness of these studies. And here's what they said. The unclear statistical methods applied by Vegan and Finkel precludes interpretation of the data with any level of accuracy. And similarly, the limitations with respect to accurate ascertainment of events by Bessaria and Finkel also preclude drawing any conclusions. So to close this video, I wanted to read 2 paragraphs from Dr. Morgantaler that he published in an editorial called The Asian Male. He says, "For whatever reason, testosterone has always been controversial. Yet those of us who treat men with testosterone deficiency have seen for ourselves the important benefits of this treatment. Those of us who have researched testosterone are familiar with an extensive literature spanning more than 30 years in which low levels of testosterone have been repeatedly associated with increased mortality and cardiovascular risk factors, and treatment with testosterone appears to improve both outcomes and risk factors. In particular, 2 high-quality recent studies demonstrated reduced mortality by half in testosterone-deficient men who received testosterone compared with the men who did not receive it. Those studies garnered minimal or no attention from the medical community or the public. However, the publication of 2 weak studies, that's the Finkel and Deegan study, with questionable methodology and interpretation appear, and suddenly there is a media frenzy that alters medical thought and practice regarding men with testosterone deficiency. Science is messy, and there will always be articles published that yield unexpected or awkward results. Every once in a while, though, it's important for the research and clinical medical community to stand up and say, no, this is wrong. We do this for science, for the integrity of the medical literature, and most importantly, we do it for the health and welfare of our patients." All right, I hope this video has been at least somewhat helpful in clarifying why testosterone has been vilified in the past, the weaknesses of the studies used to support that notion, and that's literally the best we've got. That's the best we can come up with to say that testosterone, a completely natural substance that our own bodies make, might be harmful. Every negative article, every negative publication, doctor of any specialty that thinks that testosterone is or might be harmful, those studies are their go-to. I mean, they were published in JAMA and the New England Journal of Medicine, so they have to be right? Well, yeah, those are good journals, no doubt about it. But I think they messed up when they published those studies that were so flawed, so seriously flawed. And the medical community, I think they messed up when they so readily swallowed that information seemingly hook, line, and sinker. And I'm not against telling patients that it might increase risk. That's fine. I don't believe it, but I will continue telling them that it's a potential risk, that it's listed on the package insert. But overall, we in the medical community, we really need to be a little more cognizant of the quality of the studies that we use to support our opinions. All right, I'm out. Stay healthy, everyone. I'll see you on the next video.